Good afternoon, ladies and gentlemen. I would like to thank the organizers for the opportunity to talk today about cardiovascular imaging in COVID-19 infections. As we can see here on the dashboard published by World Health Organization, COVID-19 infection affected the whole world and each of us. As of 1st May 2021, there have been more than 150 million confirmed cases of COVID-19 infection, including more than 3 million deaths. And on a positive note, more than 1 million of vaccine doses have been administered so far. So COVID-19 infection affects mostly adults and their lungs. However, we also know that the heart can be affected. And this is one of the first studies which was published in last year, and it looked at the cardiovascular imaging in COVID-19 infections in adults. It was based on prospective international survey, and it included a total of 1,216 patients from 69 countries and 6 continents. The patients were included between 3rd and 20th April 2020, and echocardiographic findings in presumed or confirmed COVID-19 infection were analyzed. Here we can see that almost half of the patients had normal echocardiogram. However, the right ventricular abnormality was present in 1/4 of the patients, and it was more common in severe symptoms of COVID-19 infection. Left ventricular abnormality was present in 1/3 of the patients, and the findings were predominantly non-specific. Severe abnormality was detected in 1 in 7 patients, and very positive imaging change management in 1/3 of the patients. But at this time, nobody knew if the findings are caused by the direct disease by the virus, or if it's the response to the systemic disease, if the findings are temporary or permanent. This is another very important study. This is a CMR study published by the German group, and this study included 100 patients with the whole range of symptoms from mild up to severe symptoms, and 33 patients required hospitalization. The median between COVID diagnosis and CMR was 71 days, and the authors included also 50 age and gender matched healthy controls and 57 risk factors matched patients. And they found out that there was statistically significant difference in left ventricular ejection fraction and right ventricular ejection fraction between recovered COVID-19 patients, healthy controls, and risk factor matched controls. They also looked at native T1 and T2 values. Just to explain, native T2 values are very important to detect myocardial edema, so the acute inflammation of the myocardium. And native T1 is important to look at any pathological findings in the myocardium. So if the native T1 is positive and native T2 is positive, then this confirms myocarditis. However, if the native T2 is negative, then native T1 would mean fibrosis or some permanent changes. And the authors found out that there was statistically significant increase in native T1 and native T2 in recovered COVID-19 patients when compared to healthy controls and risk factor matched controls. They looked also at late gadolinium enhancement, and the myocardial ischemic and non-ischemic enhancement was statistically significantly increased in COVID-19 patients. So altogether, 78 of 100 patients had abnormal findings, 12 patients had ischemic pattern of late gadolinium enhancement, and 60 patients had ongoing myocardial inflammation. And these findings were independent on pre-existing conditions and severity of the acute illness. These findings are obviously quite worrying because many of the patients had only mild disease, and this raised the need for ongoing investigation of long-term consequences. There was another study published recently, and this showed similar but much less worrying findings, with much less prevalence of these findings. And this study looked at 148 patients from 6 London hospitals, and only patients who required hospitalization and only those who had positive troponin were included into this study. CMR was performed at median 68 days after the onset of disease, and it showed that left ventricular ejection fraction was normal in the majority of the patients, in 89%. However, despite normal ejection fraction, late gadolinium enhancement plus minus ischemia was present in more than half of the patients. This is a busy graph, but we can see here that no major abnormality was seen in 68 patients out of 148. And then the rest of the patients had either CMR findings of myocarditis with the subepicardial enhancement, or they had myocardial infarction with the subendocardial or transmural enhancement. And some patients had dual pathology and some only inducible ischemia. And interestingly, 27% of these patients had myocarditis pattern of late gadolinium enhancement, and 1/3 of these had active myocardial inflammation. It is not feasible to perform CMR in all patients and repeat it frequently. However, this would be the group which should be targeted, and this should be the patients who would require repeat CMR. And then another important group is patients with ischemic etiology. 26% of the patients had findings consistent with ischemic etiology, and 95% of these had at least one cardiovascular risk factor. But importantly, 66% of these patients had no known past history of ischemic heart disease. This is just an example of a patient with dual pathology. We can see here the subepicardial pattern of late gadolinium enhancement in the lateral wall of the left ventricle, which is very typical for myocarditis. And then here we can see subendocardial scar in the anterior part of the myocardium, and this is consistent with myocardial infarction. And this is a slide which summarizes the possible pathomechanisms in COVID-19 infections in adult patients. And it is now thought that the largest part of the patients would have ischemia due to imbalance between supply and demand, with low supply caused by hypoxia, anemia, or hypotension, and high demand with fever and tachycardia. And this is because of the systemic disease and pulmonary involvement. And these patients would have ischemia mainly if they have more risk factors. And this would cause then evidence of cardiac injury and troponin release. And then there are other mechanisms, possible mechanisms: cytokine release causing stress cardiomyopathy, which is thought to be uncommon, and then direct involvement of the cardiomyocytes or disease of the cardiomyocytes by the virus, which would cause myocarditis, but it is now known that this is also uncommon, and it is not, because it was not found very often in the autopsies. And the other mechanism, we know that COVID-19 infection causes thrombotic state, and this could cause direct myocardial infarction, but this is also very uncommon. So let's have a look now at children. So in March last year, the Royal College of Pediatrics and Child Health in the UK and the CDC in the USA announced a new syndrome, which is associated with COVID-19 infections in children, and it's called PIMS in the UK, which is Pediatric Inflammatory Multisystem Syndrome, or then Multisystem Inflammatory Syndrome in children called in the US. And we can see that there are some important similarities, but also differences with Kawasaki disease and with toxic shock syndrome. The proposed mechanisms are either antibodies causing the disease and enhancement of the disease, or it might be massive cytokine upregulation causing unregulated inflammation. And this is a very important paper showing the cardiovascular imaging in COVID-19 acute phase, in PIMS patients in acute phase. This was published by the Evelina group, and I'm sure Dr. Owen Miller will talk about this paper in more detail. And therefore I move further on, and I would like to show you now a case report which is accepted for European Heart Journal case reports by the group of Inga Foges. And this showed a child with transposition of great arteries after arterial switch operation who presented with PIMS at the age of 22 months. And this child had SARS-CoV-2 immunoglobulin G antibodies, and was treated at the clinical signs similar to Kawasaki disease. The child was treated with immunoglobulin, aspirin, and corticoids, and 11 days after the onset of symptoms had very enlarged coronary arteries. And the CMR performed 26 days after the onset of symptoms showed the 3D imaging with enlarged coronary arteries, diffusely enlarged coronary arteries, however, sparing the proximal parts of the coronary arteries, which was thought by the authors that this is because of scars after the transplantation of the coronary arteries during the switch operation. And the patient underwent also stress perfusion test, the rest perfusion test, which was positive for perfusion defect. The stress test was not performed due to risk of the stress as the rest test was already positive. The late gadolinium enhancement was negative in this patient. And this is just for comparison. The cassette data showed at the age of 13 months normal coronary arteries. However, at 28 days after onset of symptoms, we can see these dilated coronaries sparing the proximal parts. And now we at the Royal Brompton Hospital looked at short-term sequelae of PIMS patient assessed by CMR using comprehensive CMR protocol. And we looked at the subacute phase. So the mean was 27 days from the onset of symptoms. And we included patients who had only, from those patients reviewed in the clinic, we included only patients who had myocardial involvement. And the 22 patients fulfilled the criteria. 11 had myocardial dysfunction, 6 patients had dilated coronaries, and 5 patients had increased cardiac inflammatory markers in the acute phase. And 20 patients were compliant with the scans, 2 patients were not compliant and were not included into the study, and 6 patients were scanned under general anesthesia, therefore in our setting in 3 Tesla scanner, and 14 patients were scanned at 1.5 Tesla scanner. And we can see here that the conventional markers were normal, within normal range in all patients. In only 1 patient had mildly decreased left ventricle ejection fraction. And so the volumes of the left and right ventricles and the left atrium and right atrium and the MAPSI-TAPSI were otherwise within normal range. The short town inversion recovery sequence, which is used for detection of myocardial edema and acute myocarditis, was negative in all patients. Early gadolinium enhancement also, and the late gadolinium enhancement at this stage in the subacute phase was positive only in 2 patients. And the pattern was intramyocardial, and it was only very small extent. And then we looked at native T1 and T2 values. Native T1 was assessed at basal and mid-ventricular level, native T2 at basal, mid-ventricular and apical level. And we compared these values with our institutional normal values for 1.5 Tesla and 3 Tesla scanner. And we found out that all mean T2 values were within normal range in all patients, then therefore excluding acute inflammation, and only 1 patient had increased mean T1 value at mid-ventricular level. And we looked more strictly at the segmental T2 values, and we can see that all values only in 3 naught were below our institutional normal values. And when we looked at the segmental T1 values, then we can see that more segments had abnormal values when assessed in 1.5 Tesla or 3 Tesla scanner. And these would suggest that these findings would suggest that there are no acute changes at this stage of the disease, and that there are some subtle changes with regard to the T1 values, showing more fibrotic, interstitial fibrotic changes, which might be permanent. number of segments with increased native T1 was associated with high CRP at the time of admission. And then we looked at myocardial deformation in these patients, and we included 30 patients after PIMS and 30 healthy controls. The median, the mean from the onset to scan was 27 days. So it was again subacute phase. And we again included patients who had myocardial, some myocardial involvement. And interestingly, we can see here that when compared with patients with controls, then there was statistically significantly decreased strain, radial strain, circumferential strain, and longitudinal strain in all parts when compared to controls. But conventional CMR parameters were normal in majority of the patients. And then we looked at the strain data, which we acquired from our patients, and we compared them with reference values for left ventricular strain and strain rate, which was published recently. And we can see that reference values have parabolic appearance with regard to the PSA. And then we found actually out that all strains in patients were above 25th centile, except of one patient when the longitudinal strain was less than 25th centile. We performed another study in our institution when we looked at longitudinal strain, and it was our echocardiography group who compared PIMS patients and patients with Kawasaki disease, and compared 40 consecutive children with PIMS and 45 consecutive non-matched typical Kawasaki disease patients with coronary artery anomalies and normal left ventricular ejection fraction. And the mean for the patients was again 29 patients, so again subacute phase. And here we can see that the patients after Kawasaki disease had significantly worse left ventricle global longitudinal strain, and when compared to PIMS patients. And also there were some segmental differences, and patients with Kawasaki disease had significantly lower strain in basal anterolateral segment, and also in basal anterior segment and basal anteroseptal segment. And here we can look at the bull's eye, and we can see how it looks in PIMS patients. So basically all segments, the mean value in all segments was higher than minus 19%, so was within normal range in PIMS patients. And in our Kawasaki disease, we can see more segmental impairment, and there were more segments which had a longitudinal strain less than minus 19%. And now this is my last slide, summarizing the cardiovascular imaging findings in PIMS patients in subacute phase, summarizing the 3 studies performed at the Brompton Hospital. And these showed basically that the conventional CMR parameters were normal in majority of the patients, that there is rapid improvement and near complete normalization of cardiac abnormalities within 2.5 months after the onset of the disease. However, subtle residual abnormalities were found in an important subset of children, and we think that follow-up studies are necessary in these children. We found abnormalities in parametric imaging in T1 values, and which would show fibrotic changes in interstitium. And then we found out that myocardial deformation parameters are within normal range, but they are lower when compared to healthy matched controls and higher when compared to patients after typical Kawasaki disease. Thank you very much for your attention.